Hello, my name is Christina Shea, and I'm the Director of Impact and Health Metrics at the AHA's Center for Health Metrics and Evaluation. In order to help prepare you for the 2030 goal setting process, we thought it would be helpful to provide a presentation that goes over the basic concepts behind cardiovascular health that was defined in the goal setting process for the 2020 goal, as well as the metrics and evaluation process that we use to monitor change in cardiovascular health over time. Specifically, I'm going to go over the concepts and rationale behind the definition of cardiovascular health, the cardiovascular health metrics and health categories that are used to define cardiovascular health, as well as the current data sources and target populations that are used to monitor progress. There's a statistical process that we go through to assess change in cardiovascular health. I'll give a little bit of information about that. And in addition to the background information, since we've been monitoring the goal over time for the last few years, we've gotten lots of feedback from different external and internal entities, and we've identified some strengths and limitations of the current approach that we're using. So I'll go over some of that with you in this presentation as well. Also, as a member of the 2030 Goal Setting Task Force, it's going to be important to understand the history of why this goal was set, how it was set, the definitions used, to consider the areas that may need revision for the definition and the goal itself in the process for setting the goals. So let's rewind back to 2010. As the 2000 to 2010 decade came to an end, the AHA Board of Directors charged a team of experts and leaders in cardiovascular health to recommend an overall goal for the American Heart Association through 2020. After several months of study and discussion, the committee presented their results to the board and eventually on to the world on January 20th, 2010. They formally unveiled the metrics for cardiovascular health and mortality that they're using to monitor progress in this goal and other key details about how the new, bold 2020 strategic impact goal would be used by the organization. This paper was published in our premier journal, Circulation. We'll be providing a copy of this paper for you, and if you have any questions about the specific background information or the metrics, you'll be able to refer to them in this document. So the overall goal that was set was by 2020 to improve the cardiovascular health of all Americans, and by 2020 reduce the deaths from cardiovascular diseases and stroke by 20%. So there's two aspects of this goal to consider. One is the concept of cardiovascular health. The second is the reduction in mortality or deaths from cardiovascular diseases and stroke. So since the concept and how we measure cardiovascular disease mortality and stroke mortality is relatively straightforward, I'm going to spend a lot of time in this presentation talking about the concept of cardiovascular health and that aspect of the goal, how we define it, and how we monitor progress. So when the original 2020 Goal Setting Task Force started the arduous task of defining cardiovascular health, there were some guiding criteria that they tried to keep in mind. They felt that the definition should, first and foremost, encompass more than just the absence of cardiovascular disease. They wanted the definition to be based on data that suggested what would be an excellent prognosis with regard to cardiovascular disease-free survival, as well as longevity, healthy longevity, and quality of life. Now, they were interested also in maximizing face validity, but also being consistent with current clinical and public health guidelines. Now, from a practical clinical perspective, they wanted to make sure that this definition was simple and accessible to practitioners to help provide the clinical health professionals with guidance in promoting cardiovascular health. So part 2 of the definition, or slide 2 rather, they also felt that the definition should be simple and accessible to the general public and individuals to provide non-medical guidance regarding lifestyle components of cardiovascular health. They should also contain actionable items. I think this is important. Actionable items in which individuals, practitioners, and policymakers could make strategic impact and make a focus to improve cardiovascular health. A major aspiration of this goal is to allow for all subsets of the population to make progress towards achieving cardiovascular health, reducing health disparities, and promoting health equity. But it also needed to be readily measured using existing and future data from nationally representative samples that would allow current assessment and monitor of changes over time. And as you can see across these two slides with all of these criteria, this was a very big order to fill when it came to defining cardiovascular health. Now, since the definition of cardiovascular health was really promoted to not be just the mere absence of disease, but to really focus on prevention of cardiovascular disease and its risk factors, there were two basic concepts in prevention in particular that were emphasized and used as guiding values when defining cardiovascular health. One was a definition of Jeffrey Rose from 1981, where he really separated the concept of high risk versus population strategies for prevention of disease. And although our current guidelines mostly focus on high risk strategies where the relative risk for disease is high, there's the concept of shifting the population distribution by potentially even lowering risk a small amount for larger amounts of people, and that approach can have a more dramatic impact on disease and prevention of disease. Also important to this concept is the idea from Thomas Strasser from 1978, and that's the idea of primordial prevention. Now, most of us commonly think of either primary or secondary prevention, or even tertiary, but the concept of primordial prevention comes before any of those three. It's really the prevention of the development of the risk factors themselves that lead to disease, not just prevention of disease. Because once the risk factors have developed, the risk for disease is high and difficult to substantially reduce. In this situation, we talk about the concept of the horse already having left the barn or bolted from the stable once risk factors have already developed. So overall, the discussion continued with critical issues related to recommending attributes that needed to be included in the definition of cardiovascular health, including controlling risk factors, reducing mortality, eliminating or reducing health disparities or promoting health equity, and also retaining or improving quality of life. The concept of compression of morbidity is really a salient idea here, where we can promote the maintenance of a high quality of life longer and longer and a smaller period of comorbidity before death. The consideration was also given to preventing disease, controlling disease, treating diseases, and also managing chronic illnesses. So, again, considering this tall orders of ideas that were considered and included in the guiding principles of defining cardiovascular health, the AHA 2020 Strategic Impact Goals, the definition of cardiovascular health includes 7 key health behaviors and health factors. Several of them are more traditional cardiovascular risk factors that have a long history of being included as major cardiovascular risk factors. But one of the benefits of this definition is really the inclusion of both clinical and lifestyle factors that all together an individual must have what we're calling ideal levels of all 7 of these components or metrics in order to have ideal cardiovascular health. Those include smoking or refraining or abstinence from smoking, a healthy diet, optimal levels of physical activity, normal body weight, optimal levels of blood glucose, blood cholesterol, and blood pressure. Now, our previous analyses in this area have revealed that using national surveillance data sets that when we look at all 7 of these factors and the ideal ranges, less than 1% of the U.S. adult population has ideal cardiovascular health, which again means having ideal levels of all 7 of these health factors. Now, not only did the committee identify the 7 health factors and behaviors that make up the definition of cardiovascular health, they also defined the metrics and the cut points for 3 categories. The categories include poor levels, intermediate, and ideal levels of health, and each of the 7 factors have these categorical cut points. So for smoking, to have a poor status of health for smoking, you'd be a current smoker. Intermediate level of health would be that you have quit smoking in the last 12 months, and ideal is never having smoked or quit within the last 12 months. The healthy diet score, which I'll get to in detail in a moment, the diet score is made up of 5 specific components, and depending on how many of the components you reach a threshold on, you are classified as poor, intermediate, and ideal with regard to the diet score. Reaching 0 to 1 component, 2 to 3, or 4 to 5 are the cut points for the poor, intermediate, and ideal category. Now, several of the components are based on regular guideline levels. So for physical activity, no physical activity is considered poor, and the intermediate level is some physical activity but not the recommended levels, and the ideal levels of physical activity are based on the physical activity recommendations for all Americans. Body weight is defined in 3 categories for BMI: is normal weight, overweight, or obese. Normal weight, overweight, or obese, yes. Again, when we talk about the health factors of glucose, cholesterol, and blood pressure, these are all based on different standard guidelines that are available for the various metrics. So we have poor categories if you are in a diabetes range, a high cholesterol or a hypertension range. Intermediate is usually a pre-diabetes, pre-hypertension, or elevated but not high level of cholesterol, or ideal levels in the ideal category. And again, it's important to emphasize that these categories of ideal, particularly for the health factors, you cannot be on treatment and have ideal levels and be in the ideal category. You must be able to reach the ideal level of these risk factors without treatment. Because again, there is substantial evidence, which also reminds me we need to share with you all, that longitudinal cohort evidence has shown that even if an individual has developed an elevated risk factor, such as elevated blood glucose, blood pressure, blood lipids, even if they're medicated back down to normal or ideal levels, their risk is still significantly higher than those individuals that risk for cardiovascular disease is significantly higher than those adults or individuals that never let their levels elevate above the ideal ranges. So there's still increased risk. And again, these categories, this ideal category is just that ideal. So again, no treatment is allowed in the ideal category, and these are really the optimal levels for the risk factors in order to have the lowest level of cardiovascular disease risk. So specifically around diet, one of the things I wanted to talk about is the principles guiding selection of the metrics. And I'm going to use diet as an example. I'm hoping this will give you information about what is in the actual diet metrics and the healthy dietary score, as well as the process and ideas and concepts behind selecting those metrics for diet. The same process was also used for selecting the other metrics and the categories for them. So for example, for diet, they were interested in looking at foods for ease of communication and implementation, also using strong scientific evidence, particularly the influence of these foods on disease outcomes or the established relationships between them. They wanted to be consistent with guidelines, whether they be national guidelines, professional guidelines, and current AHA recommendations. Flexibility was also important because they wanted to be able to allow individual variation with regard to the types of diet individuals have and or the evidence that may be different between different cultural and ethnic preferences. Also, parsimony was key. They wanted to identify a key set of elements, metrics for the dietary score that were identifiable and easy to communicate when someone follows a healthy dietary pattern. And finally, they needed to be measurable. Measurable can mean a lot of things, but particularly in this setting, I believe they were thinking about the idea of measuring both in a research perspective, if we're interested in looking at the value and the association with these metrics with the disease outcome, as well as able to be measured and communicated in an individual's dietary intake in a clinical setting. So, considering the rationale and the concepts behind selecting the dietary metrics, these are the following dietary metrics that were selected for the healthy diet score component of cardiovascular health. So in the context of a diet that's appropriate in energy balance, so energy balance is emphasized, pursuing an overall dietary pattern that is consistent with a DASH type eating pattern which is including but not limited to. And on the including these metrics side, this is what we actually use to measure. But they also left the notion in there of not limited to, so there's flexibility with recommending healthy dietary patterns, particularly on an individual basis, as long as they're following a DASH-style eating pattern. So for our metrics, we use fruits and vegetables, yes or no, a dichotomous outcome of whether or not an individual consumes 4.5 cups per day. Fish is one of the metrics with greater than 3.5 ounce servings per week, preferably oily fish. Fiber-rich whole grains needing greater than 3 1-ounce equivalents per day. Sodium is one of the more difficult metrics to attain, and that's less than 1,500 milligrams a day. And sugars and sugar-sweetened beverages less than 450 calories per week, or less than 36 ounces per week. Now, sodium I'll pull out here and mention that it is one of the nutrient-specific metrics in the healthy diet score, and it is also a 1,500 level for sodium intake, milligrams per day. This is lower than other recommended amounts of 21, 22, 2,300 that you may see with other dietary guidelines. But selection of 1,500 was really based on the previous evidence that shows that in order to maintain ideal levels of blood pressure and other health outcomes related to cardiovascular disease, 1,500 was really shown to be the optimal level of sodium intake. The debate has pursued since of whether or not 15, and prior to, I should say as well, the debate has pursued that whether or not 1,500 milligrams per sodium is an attainable amount. But regardless of whether or not it's attainable, the cut point selected of 1,500 was really based on what we know, based on scientific evidence, that individuals should be attaining in order to maintain optimal levels of outcomes, particularly blood pressure, with regard to sodium intake. So keeping that in mind, that goes back again to the levels of ideal compared to attainable, and this is really meant to show where we want people to be for optimal or primordial prevention of cardiovascular disease. Now, there's also secondary dietary metrics that are associated with the score. For our overall assessing progress, we do not include these metrics, but these are mentioned and outlined in the 2020 Strategic Impact Goals Special Report. Saturated fat, less than 7% of energy, is included as a secondary metric, as well as nuts, legumes, and seeds, processed meats, and trans fats. Not measurable in NHANES at the time, but we'll get to that a little bit further when we're talking about our data sets and our measurement sources. So, in the development of the definition of cardiovascular health, the metrics and the definition, there are many strengths that have been identified and really justify its use and the strength of these definitions. One is the strong evidence base. You'll see that in the Don Lloyd-Jones Special Report. There's extensive evidence to support not only the overall concept of cardiovascular health, having a greater number of these factors in ideal ranges, but also the cut point selected and the idea of primordial prevention for prevention of cardiovascular disease in the future and really maintaining healthy longevity as long as possible. Now, these definitions also encompass both behavioral and clinical aspects of cardiovascular health, I should say. Now, it's important to note that not only are clinical factors included in this, but behaviors are as well. Previous to this special report and this task that the Goal Setting Task Force was asked to take on, there was no official AHA definition of what cardiovascular health was. So at AHA, I know, and as well as many of the scientific volunteers that have worked on this, feel very strongly that this overall concept of cardiovascular health is a general picture of all meaningful aspects of cardiovascular health that we have strong scientific evidence to support at this time, more specifically to the time that these discussions were going on and the metric definitions were set. Practical metrics with easily categorized cut points. They were discussed and assessed in a variety of settings. You can use them in a clinical setting, in a research setting, in a counseling setting. The practical aspect of these, particularly from the healthy diet score, is one of the major strengths. And again, these metrics are actionable with practical recommendations for improving aspects of cardiovascular health according to the 7 metrics. We also there was also a lot of discussion and purposeful documentation and definition to align on the guidelines and positions of the AHA statements and scientific evidence that they support as well. So really a lot of strong evidence and thought that went into developing the definition of cardiovascular health. Now, there are some limitations that should be noted, particularly that have been brought to our attention since release of the goals and the metrics for cardiovascular health, that are going to be important to consider for the 2030 committee as we move forward. First, there's been a lot of discussion about how the data sources that have been used to monitor cardiovascular health are limited in select populations. We're using the National Health Nutrition Examination Survey data, which I'll get to in a minute, talking about which data sources we use and how we use them. But the data sources that we use are limited with regard to younger ages and certain race ethnicity groups. The categorical nature of these metrics are not sensitive to change. Physical activity, for example, you have a poor level of physical activity if you report 0 minutes of moderate or vigorous physical activity, but the range of intermediate spans from 1 minute to 49 minutes. So an individual is categorized similarly if they have 2 minutes of physical activity per week or 49 minutes of physical activity per week. So potential reevaluation of the categorical nature of the variables will be a discussion to be had for the 2030 committee. Now, select metrics are limited. Lots of people were interested in using aspects of the cardiovascular health score or the cardiovascular health definition for research purposes. But because of the practical nature of them and the interest in being easy to assess and communicate in a clinical setting, oftentimes the healthy diet score and other aspects of the definition are not able to be standardized in a research situation. For example, the healthy diet score is practical recommendations and not a measure of overall dietary quality, such as what we might see in the healthy eating index. Now, there are some metrics that are not in the current cardiovascular health definition that since the definition was identified and developed, evidence has grown to support them. Furthermore, some of the practical aspects of metrics that have not been included, such as LDL cholesterol, HbA1c, some of the additional measures that are not included but have strong scientific evidence that they're associated with cardiovascular disease outcomes, they oftentimes were not included due to the practicality of measurement and the availability of these measures in national surveillance data sets. Finally, we're getting back to the concept that the metrics and the data sources that we use to define and measure cardiovascular health were difficult to operationalize internally for AHA as an organization with regard to their goal setting, and evaluation of performance and evaluation of progress for internal programs that the AHA was implementing. So we'll be thinking about this a lot in the process of setting the goals, and hopefully as a staff member within the AHA, we'll be present and hopefully help to guide these conversations. Now, one major consideration with revision of the way that the cardiovascular health score and the categories of cardiovascular health metrics are defined is the issue of categorical versus continuous scoring. So currently, the original scoring system for metrics is based on 3 different categories, having poor, intermediate, and ideal. For continuous measures, such as physical activity, this can be limited in assessing progress or change over time with an individual, considering that the poor category is 0 minutes of physical activity per week, intermediate spans from 1 minute all the way to 149 minutes of moderate or vigorous physical activity per week, and ideal is greater than 150 minutes per week. So an individual that reports 2 minutes of physical activity per week is categorized similarly to an individual that reports 148 minutes per week of physical activity. Similarly, in the healthy diet score, the metrics that I reviewed are categorized in a dichotomous yes-no fashion of whether or not the individuals meet the threshold for the 5 components fruits and vegetables, whole grains, fish, sodium, and sugar-sweetened beverages, and the number of components they attain are categorized according to poor, intermediate, and ideal. Again, this type of assessment is limited in the sensitivity to change. So, a revised continuous scoring approach has been proposed for some metrics to improve sensitivity to change within categories. For example, diet, a more granular range of 1 to 10 within each category, rather than a simple yes-no dichotomous outcome has been proposed. We'll talk about that a little bit more when we get into discussions of the score itself and the continuous versus the categorical scoring, but just put this concept in the back of your mind because we'll be referring to it through the course of our conversations and discussions. Again, I'm going to go back to this very important concept of AHA's internal staff, from the CEO level out to the grassroots field staff, use the goals that are set and the metrics for assessing their progress towards their programs and initiatives that they undertake. So, it's going to be very important to consider that when setting a goal, choosing the data sources that are used and the metrics that are used to evaluate progress. As a former volunteer, I was very surprised to find out in the vast number of ways the strategic impact goal is used within the organization. The organization overall, the performance of AHA as a whole is evaluated based on this 2020 goal, as well as strategic planning for target programs. What types of resources are devoted to which programs and why, based on the idea of having the largest impact on progress towards the 2020 goal. So, for example, internal AHA program goals, whether it's sodium reduction programs, sugar-sweetened beverage reduction initiatives, or blood pressure improvement initiatives, are set based on these cardiovascular health metrics and currently rely on NHANES data for evaluation of their progress. So you can see the concern that if there's a small community-based program that's being implemented, there's a large disconnect between the progress that's potentially made for that program and whether or not it's going to translate into movement or impact on overall movement of cardiovascular health based on NHANES numbers. Also, performance evaluation for individual staff members are also based on whether or not the degree of progress is made on the improvement in cardiovascular health. So the success of programs that are implemented and individuals' program performance evaluations often are also based on whether or not NHANES movement is seen. Considering that programs are community-based or often implemented regionally, there's a concern and a disconnect between the local level progress that's made and whether or not we're actually able to see these changes at a national level using national surveillance data. So, moving forward, we need to consider as a committee and as a group whether internal AHA programs and initiatives should use the goals that are set as part of the overall goal-setting process, or whether additional or supplemental goals and metrics also need to be established for internal AHA purposes. So I'll stop this and thank you for your time. Again, as I mentioned, I crossed from the scientific volunteer side over to the staff side, and now more than ever I can say how grateful AHA is and all of their staff are for the time and efforts of you as volunteers. If at any time during the goal-setting process you feel the need to reach out to me to have a conversation about the goal-setting process, the current definition of cardiovascular health, metrics, data, or anything in between that might fall into my sandbox, so to speak, please feel free to reach out. I look forward to working with you on the 2030 goal setting process. I'm going to have to get used to saying 2030 goals. And I look forward to working with you. Have a great time in the process. Take care.